introduce you. So Mandy Pellegrin is our first speaker. Mandy joined the Sycamore Institute in 2016 as the policy director. She has the lead responsibility for developing the organization's research plan and conducting and curating research and analysis. Mandy holds a master's degree in public policy with a health policy concentration from Georgetown University and a bachelor's degree from Lipscomb University. Mandy brings with her over a decade of experience in health policy, including as the Presidential Management Fellow at the U.S. Department of Health and Human Services, advising senior HHS leadership under both President George W. Bush and President Barack Obama on budget policy issues, and as a health policy advisor to U.S. Representative Bill Pascrell, Democrat of New Jersey, who served on the Ways and Means Committee during the drafting, consideration, and passage of the Affordable Care Act. She began her career here in Tennessee as an intern and then bill clerk in the Tennessee General Assembly. We're delighted to have you here with us today, Mandy. Thank you for coming.
Thank you so much for having me here. Only a few of you have your cameras on, but if you've heard of the Sycamore Institute, like kind of make a wave. Okay, so most of you here have, and that makes sense because we kind of got our start doing health policy work. But for those of you that aren't familiar with the Sycamore Institute, we're an independent, nonpartisan public policy research center for Tennessee. And basically there are two things to know about us. One, we're, in the landscape of think tanks, we're the one where our staff is bipartisan, but our work is nonpartisan. So we try really hard to present objective analysis of issues. And we are a policy research center, not a policy advocacy center. So we really focus our work on trying to understand what the evidence is behind particular policy issues, what the data say, what the trade-offs are and considerations for any particular issue so that policymakers and advocates can come to their own conclusions about the best ways to address those policy issues. So everything we do is available on our website. So it's free to the public and policymakers, and we are also people. So if you have questions about policy issues, please feel free to reach out to us, and I'll have my contact information at the end. So I will share my screen now because I have a presentation for you. So today, see, I always seem to lose my people's faces when I share my screen, but I'm just going to go with it. So today I'm going to talk to you a bit about surprise billing in Tennessee, basically what it is and why it matters and some things to think about. So I've kind of already gone through what the Sycamore Institute is, so I won't go through that again. The things I'm going to cover in the next few minutes are just simply what is surprise billing, so a bit of a reiteration of some of the things that Claire mentioned. How does surprise billing affect Tennesseans? So why should we care about it? And then what are some issues to consider as advocates and policymakers think about how to address the issue here in Tennessee? So first, what is surprise billing? We like to talk about Jesse in our work, ubiquitous Jesse, to walk you through problems in our state. So Jesse is a Tennessean. He is insured, so that's great news for him. And he needs to go to his community hospital, which, more good news, is in his insurance plans network. So surprise bills usually happen in one of a few different ways. So scenario one, Jesse schedules a surgery at his in-network community hospital. He knows his surgeon is in network, so that's good. But he's also seen by some ancillary providers. So perhaps an anesthesiologist or a radiologist, Claire mentioned pathologists. And as it turns out, these ancillary providers are employees of a physician group that are not actually in Jesse's network. So that's scenario one. Scenario two, Jesse visits the emergency department, again at his in-network community hospital, and is of course seen by an emergency room physician, as you usually are when you go to the emergency room. And unfortunately, that physician is not in network. She is employed by an emergency physician staffing company that contracts with Jesse's in-network hospital, but not his insurance plan. So that is scenario two. Scenario three, he has to get to the emergency room if it's a severe emergency situation, and he needs to be transported by an ambulance. And it turns out that that ambulance company is out of network. So now the bills start to roll in. He gets all of his bills from his in-network providers. They're covered by his insurance, so that's good news. He may owe some coinsurance or a deductible, but all fairly predictable, and they're based on discounted rates that these providers have negotiated with his health insurance company. So the surprise happens when he begins to get bills from all of these out-of-network providers that we talked about. So sometimes insurance will still pay some kind of out-of-network fee to these out-of-network providers, but the patient is on the hook for the difference between what the provider charged and what his insurance company paid them. So this is called balance billing. So they are billing him for the balance between what they were paid by his out-of-network health insurance plan and the total charge. Really, what is at the heart of the surprise billing issue is that in these situations, Jesse did not have a meaningful choice over the specific providers that these surprise bills came from. You know, he picked an in-network hospital, he picked an in-network surgeon, and now he's left with potentially thousands of dollars in bills, sometimes from provider groups with names he doesn't necessarily recognize. So how common is this in Tennessee? So this is an analysis that was done by the Kaiser Family Foundation last year, I believe, and they found that of all in-network hospital stays in Tennessee in 2017, about 13% of them resulted in an out-of-network charge. And of all emergency room visits, about 1 in 5 resulted in an out-of-network charge. So, you know, that's not nothing considering that most Tennesseans are insured. So why is this important? So surprise billing is one way that Tennesseans can end up with medical bills that they can't pay. And medical bills can turn into medical debt. And this is a topic that we spent well over a year researching extensively at the Sycamore Institute. And I'm actually going to let my colleague Brian kind of present a summary of our work on medical debt. And I'm going to do that by showing you this great video. Actually, I'm going to stop sharing for just a moment and then share again to ensure that my settings are correct, because I have to make sure that you can actually hear the sound and see the video. So let's try that again. So here we go.
Whether you have health insurance or not, unexpected medical bills can create huge financial headaches. And when you can't pay those bills,
medical debt appears on more than 1 in 5 Tennessee credit reports. That's the 8th highest rate in the country, and it's a unique barrier to economic security. Unlike a home, car, or student loan, most of us don't go looking for medical debt. In fact, it's often caused by things you can't predict or control, like a trip to the ER, a surprise bill, or a dispute between your hospital and insurance. Once it's reported to a credit bureau, medical debt hurts your credit score, which lenders, landlords, employers, utilities, and others use to measure your financial risk.
Even small amounts can make it harder to get ahead, since 40% of adults in the US say they'd have trouble paying an unexpected $400 bill.
Meanwhile, debt buyers and collectors can tack on new fees and interest. Debts often get bought and sold so many times, the company trying to collect may not even have basic info like who originally sent the bill, if the patient disputed it, and how much was principal, interest, or fees. Like all creditors, healthcare providers and debt collectors also have the right to sue people for unpaid bills. Most debt lawsuits go unchallenged, and when that happens, courts almost always rule in the plaintiff's favor, even if the basis for the suit was inaccurate or the defendant didn't know about their court date. At this point, your wages might even be garnished to pay the bill, plus attorney's fees, court costs, and even more interest.
All of this can push people into a cycle of debt and make it harder to get ahead. To save, get a job, a place to live, and the sort of loans that help us build wealth over time.
While there's no silver bullet, the good news is we have a lot of options to prevent medical debt, to help people manage their bills, and to make many of these negative effects a little less painful.
Visit the link below to learn how each of these options could make a difference, from the clinic to collections to the courtroom, for an estimated 1 million Tennesseans with medical debt.
All right, so thank you, Brian, for doing that. He didn't even have to show up on a Saturday morning for it. So here we go to the next thing. So as you could see from the video, we consider addressing surprise billing kind of one of the many policy options that could be taken to help prevent medical debt here in Tennessee. So as policymakers begin to think about how to address, and as they've already thought about how to address surprise billing here in Tennessee, we just want to offer a few issues to consider. So I'm going to go through a short list of the things that we think are important to keep in mind as policymakers try to grapple with surprise billing. We go into a lot more detail for each of these items in our medical debt policy options report, which there's a screenshot here of the front of that there. So first is incentives. So the current system creates a distinct set of incentives for the specific provider types that I talked about earlier. So when individuals don't actually have a meaningful choice over the providers, there's really very little incentive for those providers to negotiate with insurance companies. They can simply take an out-of-network payment and charge patients for the remainder. The second is application. So who or what would a policy apply to? As you can see from Jesse's situations, there are a lot of actors that are involved in this process. The patient, the insurance company, the hospital, the physician groups. So who gets regulated exactly in this situation, and exactly how do they get regulated? The third item is winners and losers, and probably one of the most important things in addressing this with public policy. Any policy that addresses this issue for patients will almost certainly create winners and losers. Whether it's certain types of providers getting paid less than they do today, or insurance companies paying more than they do today. And this is really what has made this issue so politically difficult to address. The third thing to think about is patient responsibility. So in addressing surprise billing, what policymakers are really interested in is helping out patients. So with whatever solution folks come up with, how much responsibility should a patient have in these situations? For example, in some situations where states have looked at using some kind of arbitration process, or with the state agency, the patient is still on the hook for sort of triggering that process. And then finally, there are issues related to jurisdiction. So most health plans are actually regulated by the federal government. These are called ERISA plans. They're large employer plans, which is what most people in Tennessee are covered by. And so that has raised questions about what states can do if they are trying to use insurance regulation as the tool for addressing the problem. So for example, requiring insurers to pay these providers a certain amount of money. The good news is that there are a lot of smart policy people out in the country that have come up with some options that may be addressed at the state level, and I'm sure a lot of our panelists are going to talk about that. So I'm going to end with that, and this is our contact information. Again, like I said, everything that we do is available on our website, and you can sign up for email alerts there. I would also plug some other sources that this audience, resources that this audience might be interested in. For example, we routinely update data on how many Tennesseans have health insurance, what kinds of health insurance they have. We did a deep dive last year, actually. Perhaps that was earlier this year because time doesn't mean anything anymore. A deep dive on kind of what has gone on with health insurance coverage in Tennessee over the last decade, including how sources of coverage have changed over time, how deductibles have changed, and things like that. And again, if you have any questions, you can feel free to reach out to me. My email address is right there. So thanks for having me. Did you all hear the video?
Yes.
I would hope that someone would tell me that you didn't hear it if you let that go on for 2 minutes.
I promise I would have let you know.
Okay. Thank you.
Yeah, presented great. And thank you so much for that. I think that was a fantastic presentation, and you really laid out what the issue was very, very clearly. I just have one sort of clarifying question. One of the things that you mentioned at the end was this jurisdiction piece. And that's something that we've had a question about is, do you think this is an issue where legislation at both the federal level and the state level can be independently helpful in addressing this issue for patients?
I think so. There are probably people on the panel that are more qualified to answer that question, but it seems that there are some options for state policymakers to help with this issue. I believe Senator Watson was behind some of the efforts around transparency at the beginning of the process so that you better understand what physicians might be treating you once you show up to a hospital. Obviously, some of these situations, like showing up to an emergency room, you can't really plan for that kind of thing, but there are certainly some ways to better understand who may be working on you if, for example, you have a scheduled surgery. There are also some policy options that have been put forward that's more around regulating the contracts between hospitals and physician groups, for example, that could get around some of those ERISA issues. But I certainly think there's options available according to the policy research out in the world that can be done at both the state and federal level that could be helpful. And obviously we're going to hear from Georgia and what they've done there, and a lot of other states have taken some steps that might be helpful.
Thank you again, Mandy. Then we'll save the rest of the questions for you for the panel discussion. Thank you again for that presentation. I think that was perfect to kick us off.